Good afternoon, everyone, and welcome to our keynote here. This is a great program. As you know, before each one of our keynotes gets to start, I get to talk. So if you don't know me yet, my name is Pamela Dyer, and I am the Executive Director for the Fresno State OLLI. And as of 2 weeks from now, I will be celebrating my 1-year anniversary with the program. So we made it, everybody. I want to remind everyone that we still are doing our OLLI Gives Back clothing donation. And after today, you may bring your donations until next Friday, and you can bring those to the OLLI classroom or the OLLI office over in the Kremen Education Building. I want you to know that we have totally blown away the clothing closet people with the quantity and the quality of the donations. They have been just incredible, and so thank you all very much. We really appreciate it, and so do the students. Let's see. Oh, I'm excited. The spring catalog goes to the graphic designer on Monday, so we are a couple of weeks ahead of last year, which is really where we want to be. There will be a web version on our website before Christmas break. So keep an eye open. We'll send you emails to let you know when it goes up, okay? And, we are offering an OLLI gift certificate this year. So if you would like to give a gift to a friend or tell your family members that they can give this to you as a gift, the gift certificates are $40. And they're available online starting December 1st. And $40 actually equals the spring semester membership. So that's why we did that. So we have two choices. We can send you the digital copy to an email, or someone can come by the office and pick up a hard copy of it. Okay, we're not mailing them. Today's keynote has really been a cooperative effort between the College of Science and Math, UCSF, and OLLI. At the beginning of this year, I was visiting the many deans across campus when I met with Dr. Chris Myers. He enthusiastically embraced the idea of a collaboration between OLLI and his college. 2 days after meeting with him, he had me in front of his entire department chairs. So, and then in less than a week, he had hooked me up with Dr. Ellen Wu. And after a couple of Zoom calls and some phone calls and emails back and forth, we had a panel to present to you this incredible program today. And I'm just real excited, and this kind of collaboration is something that we're going to continue with the different colleges. We are having a collaboration with the College of Health and Human Services for our spring semester, and we'll be presented with research and clinical studies from the physical therapy department, and they'll be talking about balance, mind, and body. So that's going to be an exciting program, keynote this spring. All of our panelists are part of the Brain Health Sciences program and is led by an interdisciplinary experts in neuroscience who study impairments in the brain health, and which lead to people having difficulties functioning in everyday life. Underserved populations have a disproportionately higher rate of neurological diseases. And the BHSP has developed in recognition of the significant health, psychological, and economic impact of these diseases on brain health, particularly in medically underserved communities like Central California. So I'd like everyone to please give a warm OLLI welcome to Dr. Ellen Wu.
Thank you, Pam, for that wonderful introduction. Well, today our group from the Brain Health and Science program is here to talk about something we're very passionate about, Alzheimer's disease, how people can minimize the risk of Alzheimer's disease and what treatments are available. And what we always say is that our ideal hope is for there to be a cure, so we work ourselves out of a research program and have something else that we can study. First, what I wanted to do is introduce you to the backgrounds of my wonderful colleagues that will be talking today that can help you think about what types of questions you want to ask us. So in the first hour, we'll be presenting about Alzheimer's disease. I'll be talking about what the disease is. Dr. Lent will talk about what happens in the brain in Alzheimer's disease as an extension of what is Alzheimer's disease, and Dr. Alving will talk about treatments and risk factors. And so speaking of Dr. Alving, she is the Director of Clinical Programs for the Brain Health and Science program. She's a board-certified neurologist, and she has subspecialties in behavioral neurology and neuropsychiatry. She completed a residency and research fellowship in computational neural modeling at the Mayo Clinic, and she is currently a professor at UCSF Fresno's Medical Center and the director of their Alzheimer and Memory Center. And so there she utilizes her vast clinical expertise to help diagnose and treat people with Alzheimer's disease and other dementias. Importantly, she has many achievements, another being that she's the principal investigator of our local California Alzheimer's Disease Center grant. And the California Alzheimer's Disease Center is a leader in educating people about Alzheimer's and in improving treatment. She's also the director of the UCSF San Joaquin Valley Prime program. This is a very important track in the UCSF School of Medicine that recruits and trains medical students to come back to our area to help with treatment. And she's also the David George Rowe and Stephen W. Rowe Endowed Chair for Teaching in Neurology. So in addition to being a wonderful clinician and scientist, she's also an expert in teaching and training physicians. Dr. Lent is also my esteemed colleague here at Fresno State. He's the Director of Research Programs for our Brain Health and Science program. He is a professor and associate chair of the Department of Biology at Fresno State. He completed his postdoctoral fellowship at the University of Sussex, and he is a neuroscientist and expert in using animal models to study Alzheimer's disease. And his subspecialties are in behavioral neuroscience, systems neuroscience, and molecular and cellular neuroscience. So many types of neuroscience. And really his expertise is in learning and memory. And that's extremely important in that he studies the roles of proteins and genes and how they affect how people think, and how that leads to Alzheimer's disease and other behavioral changes. In addition to that, he's also a wonderful teacher. He's a leader in expanding interdisciplinary education for our STEM students. And so in addition to having a neurologist and a neuroscientist, I am a board-certified clinical neuropsychologist. So what neuropsychology is looking at brain behavior relationships and using that to diagnose people with neurological diseases. I did my postdoctoral fellowship at UCLA, and after that, I was recruited to the faculty at the UCLA Alzheimer's Disease Center, and back then, I was co-associate director of the center. I was the founding director of the Cognitive Neuropsychology program, where we utilize experimental tests to do better diagnosis, in addition to clinical tests of patients with Alzheimer's, and I was also the director of the neuropsychology program for the entire Department of Neurology. So I moved back here to Fresno State, where I'm the director of the Cognitive Neuropsychology Lab. I'm also an adjunct professor at UCSF Fresno, and Dr. Lent, Dr. Alving, and I all work together. We've collaborated on Alzheimer's research, and my expertise is in the early identification of people at risk for Alzheimer's. And so I wanted to mention that I'm originally born and raised in Fresno, and I went to Fresno State, got my undergraduate and master's degrees here, and my ultimate goal was to come back to this region for several reasons. One of them being that I wanted to help the people in the region who have these diseases. There's not a lot of research coming from this area, not enough people like Dr. Alving, who's amazing, to help diagnose and treat people. And so what I wanted to do is build something here at Fresno State like we had at UCLA. And so hence we have the Brain Health and Science program. And that might make you ask, what do we mean by brain health? That term is used a lot. So brain health, by definition, is those skills that are used in remembering things, learning new information, planning, concentrating, and making decisions. And so brain health is very important to everybody, for all of us in our day-to-day lives. But when people have neurological diseases, such as Alzheimer's disease, it has a very deleterious effect on our brain health. And what we know is that underserved populations have a higher prevalence of disease. And so what do we mean by underserved? Underserved means less access to medical care and less access to treatments. And the San Joaquin Valley in Fresno is a very underserved population. And so some of the contributions to an increased rate of neurological diseases in our region is that people tend to have more health conditions. There's fewer educational opportunities in the region. There's higher rates of poverty and overall increased exposure to adversity. So all of these things are prevalent in the Fresno area and the San Joaquin Valley. And so our program is here to help with improving treatments and filling that gap. So the Brain Health and Science program, what is it? I wanted to talk about it very briefly before we talk about Alzheimer's disease. We do education, we do science, and we do clinical training in neuroscience and brain health. And the goal is to train students so they'll come back to the region like I did and fill that gap with that need for brain-centered health care. And so our overall goals, we want to educate not just healthcare providers, but future researchers and people who will be advocates for those with brain health issues. So not just doing the research and providing the healthcare, but also providing very important services, such as support groups, educational programs that are very important for the community. Definitely, we want to conduct cutting-edge science on identification and treatment of the disease. We'll all talk about this more, but the earlier you can identify the disease, the earlier people can get very needed treatment. And what we see is that in underserved regions, people tend to get diagnoses later. And so there's missed opportunities for early treatment. We want to provide clinical training for students at local medical centers like Dr. Alving does, and we want to implement what we do in the community, raise awareness, provide support, promote engagement between healthcare providers and researchers and people in the community. And so we feel like we're taking another step towards that goal today, so we're very excited to be here. Now, for our research programs, we take a team science approach, so we have people from all over collaborating with us. Alzheimer's disease is a huge puzzle, and you'll hear more about how there's genetic elements, there are multiple elements of the disease. We have to look at the neuropsychology, the neurology of it. So it takes a team of people to work on this puzzle. And what we're doing is mentoring students that work across our research labs to help train them in this team science approach. And we do have disease-themed cores. So all of us that are speaking today are from the neurodegenerative disease core. So Alzheimer's disease is one of many neurodegenerative diseases, meaning that the disease is progressive and affects the brain progressively, and that then affects behavior and memory progressively. There's also Parkinson's disease, which is highly common in this area. The other disease cores involve trauma, mood, anxiety disorders, and health analytics. And so because this disease is so multifaceted, we also work with scientists across the world. We work with people from UCLA, UCSF, Stanford, multiple institutions. And so overall, our goals are to really, the major goal is to become a major hub for science and education for brain health in this region. We're establishing a core of brain health experts to work together. We want to train students clinically and in science, as they're going to be our next generation of Alzheimer's scientists and clinicians. We really want to engage the community, because the whole goal of this program was to help the people who live here. And really advance knowledge of brain health in underserved patients. And this will have effects not just locally, but nationally and internationally. So now on to our very important topic. What is Alzheimer's disease? So a lot of people will say, well, what's Alzheimer's disease? What's dementia? Are those the same thing? Are those different things? So Alzheimer's disease is a disorder that starts in an area of the brain that's involved in transferring new memories to long-term storage. So you might have heard people say, well, my friend doesn't have Alzheimer's disease because maybe they forget what happened yesterday, but they can remember what happened when they were 7 years old or when they were in high school. Well, unfortunately, that's how Alzheimer's disease starts, because it begins in a region of the brain that helps us retain new memories. Those old memories have already been transferred to other regions of the brain and are intact. But this brain area helps us store new memories, and so it's those new memories that are affected. So forgetting recent events is often the first symptom. And as the disease progresses to other areas of the brain, other thinking skills are destroyed. And it gets to the point where then it progresses, and then a person's ability to complete everyday activities to maintain independence, so being able to manage their finances, to manage transportation, to socialize like they used to, all the way to, in the later stages of the disease, just being able to manage eating. Going to the restroom gets affected. And so that's when it becomes dementia. By definition, it's when someone is no longer independent because their thinking skills have declined so much. And Alzheimer's is the most common cause of dementia in older adults. In fact, 6.2 million people in this country have Alzheimer's disease. And 1 in 9 people over the age of 65 years old has Alzheimer's disease, and nearly 2/3 of those are women. And it's the 6th leading cause of death. And that's why we are so passionate about tackling this disease and doing something about it. And so the overall consequences of the disease, as I mentioned, it affects memory early on. Up here it says episodic memory. It's memory for recent events. And then as the disease progresses, it affects language. People might have some word-finding difficulties, sort of like that tip of the tongue phenomenon, when you feel like, I know that person's name, but it gets difficult to retrieve. They have problems with executive functions, and what those are those higher order skills that us humans are very good at, like multitasking, developing strategies for what we're doing for the day. Working memories listed. This is when you're multitasking. And as the disease progresses, attention gets worse, especially sustained attention. It gets harder to focus for long periods of time, and visual spatial skills are affected. And this is knowing where things are in space. And in everyday life, that could be something like getting lost in familiar places. I mentioned how everyday functioning with activities of daily living are affected, and there are a range of different psychiatric symptoms that come with the disease, such as anxiety and depression in the later stages. What we do know is there's a disproportionate impact of Alzheimer's on underrepresented groups. Older Black Americans are twice as likely to have Alzheimer's disease compared to their Caucasian peers, and older Latinx adults are 1.5 times more likely to have Alzheimer's disease than their older Caucasian peers. And so our region is very diverse in many ways, and so this tells us this disease is important to study and treat and find a cure for, but it's especially important for the Central California Valley. Now, what is mild cognitive impairment? That's a term that's used a lot. It's not Alzheimer's disease, but it is a risk state for Alzheimer's disease. And what that means is people who have a mild cognitive impairment are more likely to develop Alzheimer's disease. And what MCI is when someone has very mild difficulties with thinking skills. It could be with memory, it could be with other thinking skills, but what's different with mild cognitive impairment is that these people are still independent in their everyday lives. And so mild cognitive impairment has been the focus of a lot of research. The reason being that when treatment is applied early, it's the most effective, and it's important to initiate treatment early. So now we have something called preclinical Alzheimer's disease. And what's been discovered is that markers of Alzheimer's disease in the brain, which Dr. Lent will talk about, but these can be found in the brain decades before the first symptoms of the disease starts. And this can be identified with brain imaging and with our recent advances in different biomarker tools. And so it's been discussed, is this a potential stage of treatment then before the disease starts? There's some pros and cons that have been discussed with that because of different side effects of treatments that Dr. Alving will talk about. But I wanted to set the stage for thinking about, what is the continuum of this disease from preclinical Alzheimer's to mild cognitive impairment, all the way to Alzheimer's disease, and what we can do for diagnosis and treatment. And so now I'd like to welcome Dr. Lent, who will talk about the biology of the disease and what you see in the brain.
So thank you, Ellen, and thank you all for joining us today. So let's try to understand the brain itself a little bit and what's going on as this disease is starting to progress. So here we're looking at a nice set of images of a reconstruction of what's happening during the process of the brain degenerating as a consequence of developing Alzheimer's disease. So the brain is of course, I'm a neuroscientist, so the brain is super cool, and I love to learn everything I can about it. And so the brain itself, when you're born with more neurons than you need and more connections than you need. And then over the first 25 years of your life, you kind of sculpt it and shape it to be the person you are as an adult. And then about 25 years old until you're probably 45, 50, the evidence is still being determined, your brain is pretty stable. And then you reach about 50 or so, and then suddenly your brain starts to degenerate. And so this happens to everyone, and there's normal age-related degeneration. And by the time you're 65, normal individuals are losing about 1% of their brain mass per year, and that's normal. But when it becomes abnormal, when you have accelerated loss, that is seen in something like Alzheimer's disease, where now you're losing 5% per year very early, and then in the later stages, up to 10+% per year. And so what this image is showing here is a very rapid loss. So this is when we actually have a diagnosis of Alzheimer's disease. And this is out of some research from the Thompson lab at UCLA. And we're looking at regions that, as we see that it getting wider here, that is accelerated loss. So it's an increased loss compared to normal aging individuals. And some of the key areas that we have losses, and I'll show it again in the next slide, is shown down here. And this is the area that Dr. Wu is referencing to being really critical for learning and memory. Also found in that area is this region that is really critical for regulating emotion and things like aggression. And that's another symptom of individuals suffering from Alzheimer's disease, is they often get angry or frustrated more often, and that's a consequence of some of this neural loss. So looking at rather now a still image. And here we're looking at the whole brain. And what we were looking at before was that if you would take the brain and just cut it right down the middle and open up and look right down the middle. And so the areas that we see being lost very early in the initial stages is this area. It's called the temporal lobe. The name is not too important, but that's the area that is going to contain this structure that is really critical for taking new experiences that you have and forming the memories around those experiences. Again, this is also where you're going to find the area that's really critical for regulating emotion. So as we start to see the progression of the disease moving forward, we start to see these other areas get brighter white. So this area that's up in the front here that we see, and at this further stage here, is that area that is really critical for helping you plan out your day-to-day activities. It's really critical for maintaining attention. So this is a higher level area of thinking. And then as we move towards the back here, what we're looking at is this area that's really critical for vision. And so Dr. Wu also mentioned that the individuals that suffer from Alzheimer's disease also have issues with visual spatial attention. And that's regulated in part not only by this front area, but also this back area that is really critical for vision. So we're seeing that these areas are breaking down at an accelerated rate. But what does it actually mean to break down? And so as the nerves or the cells within the brain are degenerating, it's usually due to the aggregation of proteins. And so here I'm looking at kind of a cartoon representation of a healthy neuron and then a diseased neuron. So this is a neuron that is going to contain these abnormal proteins that have aggregated inside. And so what the nerve needs to do to function is to send signals from one area to the next. And so its integrity is highly regulated. But as these proteins start to aggregate due to different pathological means, it causes these neurons to lose their integrity and start to lose their ability to communicate, and ultimately they break down. So when we're looking at a neuron, one of the things that we see coming from it is this really long extended portion. This is called an axon. And this is where we send signals. And so contained within this long area are these elements that create essentially like a highway system. And so once Alzheimer's disease starts to take hold, this highway system breaks down, and then it further accelerates the buildup of these proteins. So here's a cartoon. Hopefully you can kind of see it. What we're seeing is the breakdown of some of these areas of the brain. So here's the normal highway system. And we are moving things around, helping maintain integrity and structure. And then as Alzheimer's disease takes hold, suddenly this highway system breaks down. And we see it falling apart right here. And as it falls apart, our brain is not capable to handle this excessive buildup of these proteins, and they start to clump together. And so there are two proteins that are really critical in the development of Alzheimer's disease, and one of them is called beta amyloid, and this beta amyloid is what causes these things called plaques. The second one is the tau protein, and tau protein creates the tangles that we see in the neural tissue. And so we can see the consequence of these buildup of these proteins is ultimately what is causing neural tissue to die and for the brain to lose its mass at an accelerated rate. So let's zoom out and look at this additional cartoon representation of a neuron here. And so here we have this neuron, this cell at the top, which is receiving a bunch of signals. And here is that highway system that I was mentioning. And the goal really is to send signals from one end to the other end so that you can tell your hand to move, your foot to move, so that if you're looking at a ball flying towards you, you understand that's a ball. It sends a signal from your eyes to your brain to the area that recognizes what you're seeing. And so as those things start to break down, you have this pathological buildup of different proteins. And so some of them that are highlighted here are ones that I mentioned before. And here is this beta amyloid, here listed as A beta, and tau, which is listed here as P tau. There's other things that can start to happen as this disease progresses. You start to have other proteins that are building up in and around the cells that have died that are there because they were components of the cell before. So here, these are called neurofilaments, and neurofilaments, again, are just more of the structure that helps maintain those neurons. So what we can do now and what we're getting better at is that we are able to actually try to see how these different proteins are building up at different stages of the disease. So many years ago, decades ago, really the only way to definitively diagnose Alzheimer's disease was post-mortem. But we're getting better at seeing how these proteins are changing in levels as we progress through the disease. And so this area right here is looking at these proteins in a fluid called the cerebrospinal fluid. And this is the fluid that coats your brain and coats your spinal cord and helps provide support, and is really critical in helping regulating the chemical environment of the brain. So of course, as these cells start to degenerate and break down, their components are going to be found in the CSF. So one way in which we can possibly detect early stages of Alzheimer's disease, all the way up to much later stages, is to actually extract that cerebrospinal fluid. And you can do that through something like a lumbar puncture. Well, the cerebrospinal fluid is a set of fluid that actually is recycled through our brain a couple of times a day. And it does this by going into our bloodstream. So, well, since it goes into our bloodstream, maybe we can actually detect some of these in our blood. And so techniques are being developed and are getting better and better to be able to detect the levels of beta amyloid, the levels of tau, and these other protein components that are forming or building up due to the degeneration of the neurons. So a lot of work has been done into understanding when these things start to develop and build up, and when we actually are able to diagnose Alzheimer's disease. So this is a study that was published just this year, coming out of the New England Journal of Medicine. And it was a very large study to try to understand when can we detect some of these proteins at levels that are different in people that ultimately develop Alzheimer's disease versus normal or normally aging individuals. And what they found is that something like that beta amyloid, which is this A beta 42 up here, can be detected almost 18 years prior to the development of Alzheimer's disease. And we can see some of these other things like tau and other components that we talked about are actually starting to change 10, 15 years before we're actually seeing individuals being diagnosed with Alzheimer's disease. So these types of studies tell us that there is the potential to catch these conditions very, very early. And if we can detect them very early, we can intervene very early. And this right here is showing how some of these different levels correspond to some of the different stages of cognitive impairment. And so here we're looking at cognition as some level. And so we have normal level of cognition here, and then we see declining over time. And we can see that there is a function of the levels of amyloid, tau, that are actually going to predict, in a preclinical form, the development of Alzheimer's disease. And some of the other things, which are kind of the more classic or historical approaches by looking at, say, images of the brain or post-mortem, brain atrophy isn't really starting to happen at a noticeable level until you get to the level of mild cognitive impairment to the Alzheimer's disease differentiation line. So by having the ability to understand what's going on at these levels is going to allow us to really target therapies very, very early. And what's even really cool is that we're getting better at developing new techniques to actually identify these different proteins. So before, it was brain imaging, cerebral spinal fluid, and blood testing. But we're starting to develop ways to do it through urinalysis, saliva testing, looking at your teardrops. We're able to see things at very small levels that might be informative. So things are becoming very, very promising to catch it at this stage, 20 years before you actually have the issues that might slow or even halt the progress. So I'm going to spend the last couple of minutes just to really plug kind of what I'm trying to do here at Fresno State to understand the disease. And so I am an individual who studies this in animal models. And so why do we study it in animal models? Do animals get Alzheimer's disease? Some animals do get things that appear to be similar to Alzheimer's disease. They do get age-related issues. But I study it specifically in fruit flies. So why do I do this in fruit flies? Well, it's very easy to do, and so I'm an individual who really focuses on the tau pathology, not only because it's involved in Alzheimer's disease, but it's involved in other types of dementia, like frontotemporal dementia. It's also involved in things like CTE, which is due to concussions. And so what we do in my group is to really understand the expression of tau within the brain, and we really target areas of the brain that are responsible for learning and memory. And then we try to see what happens as this progression, the disease progresses over time. And we look at learning and memory, decline in these behaviors, and we correlate them with things like expression of the different levels of tau, which we were just showing that if we know something about how it's building up, that tells us something about the progression of the disease. But one of the really cool things that we can do in animal models is that we can ultimately use things like imaging techniques. And so this video might not play, I'll try, there it goes. So what we actually do is we can express tau in our fly, and we are able to simultaneously record from their neurons. And we can do this over a long period of time, and we can see how the expression of tau correlates with the breakdown in neurons and the decline in cognition. And being able to target these microcircuit or very tiny deficits within the brain at the very, very early stages really informs us the best ways that we can create treatments and therapies to help the very early stages of the disease. So I think that's a good time, and I can pass on to Dr. Alving, who will really dive into some of the therapies and treatments that have been developed.
Thank you, Dr. Lent, and thank you all for coming. I'm going to talk a little bit about, I pushed the wrong button, sorry. Yes, here we go. About treatments and risk factors and how to avoid some of those. So first of all, just because I always have to say this, I have no financial relationships, and some of the things I will discuss will be off-label, meaning the FDA hasn't approved them for use in that way, but as physicians, we often use them anyway. So starting first to talk about treatment options, and it's going to build on what you've heard about with the pathology, and then I'm going to put the risk factors and recommendations for how to try to mitigate risk at the end. So available treatments for cognitive deficits include both symptom treatments and treatments that modify the underlying disease. The way you can think about it is symptomatic treatments are similar to if you take an antihistamine when you have a cold. The antihistamine will dry up your nasal passages, but it really doesn't address the underlying virus because it's an antihistamine. But it does, for some people, make you feel better. If you take something that actually, addresses the virus and is an antiviral agent, then that would be a disease-modifying treatment. Okay. Let's see. How about that? Okay. So we have briefly the symptom treatments and the disease treatments where we target the actual disease. The symptoms, we're targeting the symptoms the way we do using an antihistamine for a cold, and we're just targeting the symptom. And then with the disease-modifying treatments, we're actually targeting the Alzheimer's disease, just like if you have a cold and you took an antiviral agent, it would attack the real reason. So talking about symptom treatments, there are two kinds of symptom treatments that we use, and I have put in the years in which they were FDA approved. So you can see we've had these medications out for a fairly long time. Since the late 90s, early 2000s, we've had what we call the cholinesterase inhibitors, and since the early 2000s, we've had the NMDA receptor antagonist known as memantine. And you may recognize some of these names. I've put the generic followed by the most commonly known brand name. These medications really work at that cellular level, the intercellular communication. So acetylcholine, or ACH, is a chemical that's used from one cell to communicate with another cell. And in Alzheimer's disease, it's low, and that affects the memory, among other things. And so this medication prevents it from being broken down as quickly. And so you end up treating the symptom by treating that chemical. And the memantine is a medication that affects the receptor for excitability. And so it dampens the excitability, and you have less cell death if there's less excitability of the cells. And it's interesting to note, for those of you who have a little bit of knowledge about dementias, we know there's other kinds of dementia than Alzheimer's disease. Alzheimer's disease is just the most common type. And there's something called Lewy body dementia, which is associated with some Parkinsonism and some sleep disturbances, as well as some other things. Those patients have even lower levels of acetylcholine and tend to respond even better to the cholinesterase inhibitors. So if I see somebody, and they also often, Lewy body and Alzheimer's disease coexist in up to 30% of patients. So if I see somebody that's having some symptoms that are a little bit like Lewy body, I will definitely encourage them to take these medications because they may actually have a big benefit. Speaking of benefits, what is the benefit of using these medications? I've put here a couple of slides, one from a cholinesterase inhibitor, donepezil or Aricept, and one from an NMDA antagonist, memantine. And basically you can see, and let me see, yeah, you can see that when two groups either start the medication or don't start the medication, there's some benefit. Interestingly, even in the placebo group, there's some benefit. And then the placebo group goes down in this manner. There's a little break here. The treated groups do better, and then they tend to do better over time, though they too continue to go down because it's not treating the underlying disease process, right? It's just treating the symptoms, and the disease is progressing underneath. And it's interesting to note that in this case, when you take away the medication here, these patients fall almost all the way down. They're basically back where they were because you're not treating the symptoms anymore. If you have a cold and you go off the antihistamine within, a short period of time, you still have the cold, well, your runny nose may come back. Same kind of idea. Similarly, we see similar data points with the memantine where, everybody, even the placebo, gets a little boost and then they get a little bit worse. And this is time, by the way, versus various functional measures. And here the memantine, they did very well, and then they continue to go down. And then this one is not a washout, it's just a longer time. So those medications do give you apparent benefit, even though they don't treat the underlying disorder. People do better in everyday life. Now, is this getting hit out of the ballpark? No. Many people really just kind of maintain in real life. Some people get a little better. Some people maintain kind of apparent stability for a while. And other people, it doesn't seem to really change it. And there's a variety of reasons for that, and it's hard to know. But then let's take a look. You might say, well, how do you know when to go off? Let's take a look at the long-term treatments. And here we have two different measurements of how people are doing. And here, and let me see if I can, yeah. In the first scale here, we have the, in the first two, we have the combo, which is the up here, we have the cholinesterase inhibitor and the anti-NMDA, so the donepezil, Aricept, and the memantine. And notice that over time, that combination did better than those people at the bottom who either had placebo or had just the cholinesterase inhibitor. And if you look at any given time, you can see, okay, yeah, each curve is, they're doing a little better. But the other thing is, if you look at the time that it takes to get to a certain spot, there's a big difference in the time when it takes to get to some of these spots. So if you're thinking about, okay, how long does it take for somebody to go to the nursing home or something like that, if that's what they do, there may be, months or even a year or something that could be different. And so both of these activities of daily living and the dementia scale score showed improvement over the long term, and this is about 4 years on this experiment here. And then here's another study where they looked at the combination. Again, that's the green, the memantine and the donepezil. The red is the donepezil alone, and then the black is the placebo. And then that goes out for longer time, many years, over 10 years for some of them. And you can see that, again, being on this combination really was quite beneficial. And again, if you look at how long it takes for somebody to get to a certain place, with this, with no medication, 4 to 6 years to get here. If you wait, you could be as long as 10 years. So there is a benefit, even though the curves, you could say, well, the curves are still going down. There's a benefit. Where you're going. So let's talk a little bit about diversity. Dr. Wu talked about the fact that, underserved populations tend to be more affected. So there was only really one study that I could find that really looked at this, and it was by our 10 group California Alzheimer's Disease Centers, led by Jerry Tinklenberg at the Stanford Center. And this was looking at people who were treated and not treated. And it was very interesting because the study was developed right around the time that these drugs came out. So there was quite a cohort of people who hadn't had the drugs because they weren't available, and then people who did have them. And for the overall group and the Caucasian group, there was a difference. But if you looked at the two groups here, let me show you the slides here. The top yellow line is the donepezil group. People who had donepezil who were Caucasian. The second yellow line is the Caucasian people who did not have donepezil or cholinesterase inhibitor. And there is a difference in the rate of decline. And then the other two here really aren't very different, and they're the ethnically diverse group, and it didn't really make a difference in this. Now, the numbers are small, and you all might also say to me, well, Dr. Alving, why this group that is not on the medication started out so much lower functioning than the ones that got the medication. And again, that might also be a socioeconomic type of process, particularly early on when the drugs were hard to get. They were not generic. And I remember, certain formularies had them and certain didn't. And if you were in a closed system, they may or may not let you have it, that sort of thing. So there's a lot here. But what do we tell people who are ethnically diverse? We don't really have good data to tell them. I still recommend that they consider the medications, but we don't have stellar data to base that on. So let's talk now. Let's go from the disease-modifying therapies that have been out for at least 20 years and talk about the disease-modifying therapies. These are the therapies that actually address the underlying disorder. Okay, so I think Dr. Wu and Dr. Lent have talked briefly already about that there are two kinds of proteins that are deposited in Alzheimer's disease. One of them is amyloid, and that's seen in the plaques, and then one of them is tau, which is seen in the tangles. And amyloid occurs first. It's kind of the thing that gets the ball rolling. The current new medications for Alzheimer's disease that target the underlying disease process target the amyloid protein. Now, there are drugs in the pipeline that are going to target tau, and there's clinical trials out there right now for these types of medications. Let's talk about why amyloid. And this is similar to the slides you've already seen. This is the earliest slide from, Jack, the earliest graphs. And here you can see the amyloid, which over time comes and peaks fairly early. And here you can see the medial temporal lobe tau, and then the tau in the, that's that temporal lobe that Dr. Lent was talking about, and then the tau in the outer portion of the brain, and here you have neuronal death, and here you have cognitive changes, okay? And these occur a little bit at a time, and the amyloid tends to occur first, and then the tau. So for a long time, people have wanted to attack the amyloid protein, since that's the first protein. If you can really get your, work started on this amyloid protein, you might be able to prevent all the processes that follow. Because if you think about this, it may be, and there's much thought that and some evidence that there is, the amyloid protein starts a cascade, which then starts the tau protein off. And if you don't have the amyloid protein, you might be able to prevent the rest of this cascade. And the other thing to remember is what you were hearing earlier. This amyloid protein gets laid down long before people come in with symptoms. So if you can break that early, it might be a good thing. Now, what they've been trying to do is treat amyloid in Alzheimer's disease, and they used to be doing studies with anybody that had Alzheimer's disease, but then they're getting smart, and they're starting to really target the earliest of these patients. So let's talk a little bit about these disease-modifying therapies. What are they? There are a couple of drugs out there, and I'll talk about the drugs specifically, but they are monoclonal antibodies to amyloid. What does that mean? That means that they're antibodies that are identical. They're built in a way that every single antibody looks like the other one. So antibodies are things that run around in the blood and clasp onto certain proteins, and then the body says, oh, there's an antibody on that, I need to get rid of it. So they're made to clap onto antibody into amyloid in the brain, and then the body gets rid of that amyloid. That is how they work. It was originally the result of a mouse model where somebody said, well, let's just try to vaccinate against, Alzheimer's disease. And they even did human trials, but it turns out if you vaccinate against it, you kind of develop inflammation, and it didn't work too well. So now you passively give antibodies, just like we do with many other diseases, many autoimmune diseases. We have antibody infusions and that sort of thing. So this is not out of the ordinary for drugs that have been developed. The question is, can we get it to work for Alzheimer's disease? And there were many drugs in the pipeline that did this kind of thing, and many drugs failed. There were multiple failures. And I think the drug companies were just about to kind of be like, I'm not going to do any more of that, when there were some that actually started working. And here you can see an MRI, which is structural. It shows you the structures of the brain. And then here you can see an amyloid PET, where it lights up wherever there's amyloid. And you can see that nice red, so there's a lot of amyloid here. And then you can see how a tau PET might look. The tau is first, this amyloid is spread pretty widely, but the tau is still concentrated in that temporal lobe, because that's where, the tau starts after the amyloid and then spreads as well. So what are the disease-modifying therapies? You may have heard about them. And there were actually 3. I deleted the first one because it came out with a lot of controversy, and they eventually withdrew it from the market when the others came out. So we're not going to talk about that one today, but aducanumab or Aduhelm you might have heard of. Lecanemab, also called Leqembi, and donanemab, also called Kirsula, I think. I don't know that brand name very well. I usually refer to drugs by their generic name if possible, are the two, and there were studies that were done that were used to get the FDA to approve these medications, and the one for lecanemab was called Clarity ID. They always have cute names for their things, and there's acronyms, right? I don't know what Clarity stands for, but who wouldn't want their study to be called Clarity, right? And then donanemab, Trailblazer, Alzheimer's too. So that's great. Trailblazer's another one, though it did come after lecanemab. And lecanemab was FDA approved in July of 2023, and donanemab was approved in July of 2024. So they're very new drugs. They've been out for a year and a half a year, respectively. The mechanisms are sort of similar. They both attack amyloid, but different forms of it, okay? We talked about the fact that amyloid can clump up in these plaques, almost like, think of it as kind of a garbage heap, you know? And it may have a different role than that, but that's kind of what it looks like. And that's what donanemab, the newest medication, targets. The other one targets the amyloid fibrils. I'll keep talking for a minute while somebody helps me fix that. I don't think I touched anything, but maybe I did. The difference, there is a little difference in the trial. You know, basically with these trials, you take two groups of people, you put one group on the medicine, you put one group not on the medicine, and you give them a sham infusion or something. Now, you might have two different strengths of medicine, that sort of thing. Thank you. The difference was in the donanemab trial, which is, it's an interesting difference. One thing that I mentioned is the MRI and then the amyloid PET. You know, to get these medications, you have to have either the spinal fluid show you have amyloid or an amyloid PET. So they said, okay, we're going to get an amyloid PET, and then we're going to follow the amyloid PET through the study. And if the patients or subjects lose the amyloid positivity in their PET, then we're going to take them off the medication because we've done our job for them, and then we'll keep following them. We won't tell them that they're off the medication. We'll give them the sham, you know, infusions. And so that was one thing that was a little bit different in these participants. Another thing I'd like to stress is, again, the diversity issue here. And you can see that we have the U.S. enrollment and then the total study subjects. Let's see. Yeah. Okay. So this is the U.S. enrollment in both of these. There are data from other countries, but not as much as the U.S. was the main, had the most, from what I could see, that might make these numbers a tiny bit better. But as far as the U.S. population, you can see that the percentage of total subjects in the study that were Caucasian was very high, particularly in the U.S. enrollment of donanemab. And the other, compared to the percentage of the U.S. population, and these others were fairly low comparatively. So that, again, how do we advise our patients if we don't know enough about what people look like in these studies? And you may say, well, it should be the same, you know, but it turns out it's not always the same, and there are differences, and if we don't study them, we won't know them. Another thing to just bring up in terms of diversity and that sort of thing is the ApoE status. And you may have heard about ApoE. ApoE is a gene that, as I think you heard before in Dr. Lent's talk, can make, Alzheimer's disease occur earlier in different people. But it turns out it has a huge effect on the side effects of these medications. And we'll take a look at that in a minute. But the effect that it has on the side effect of these medications may vary by ethnicity and race. So, an ApoE4 in a Caucasian may have a different effect than an ApoE4 in somebody who's African American. And there's some data to maybe support that, but we still don't have a lot of data points. And we don't know how they may affect other side effects, that sort of thing. So let's look at the results of the study. These are a primary endpoint and a secondary endpoint. So basically, these graphs look kind of similar to what we looked at with the symptomatic treatments. Now, the other thing to note is that it doesn't stop the progression. It just slows it down. It doesn't reverse it. It slows it down. But again, if you just look at a level of function, it takes a lot longer to get there. And this is only over 18 months. This curve, if truly this goes on for longer periods of time, you're going to get wider and wider divergence. So even if somebody can say, well, you look like you're 6 months behind, but that's at 18 months. What if you were on, what if you look out over 3 years? We don't know, because we don't have those data yet. The other thing is, this is clinically how the subjects are doing. This is what happens to the amyloid burden on the PET scan. So again, it goes down. In the placebo, doesn't really touch it, okay? So it goes down. This is the lecanemab that's been out for a year and a half. The next slide, we'll look at the donanemab with the Trailblazer. Very similar results. The placebo is below, the treatment level is above. The difference is that in these two is one of them has they've also done a tau PET scan. So remember we talked about the fact that amyloid comes first, tau comes second. They've done a tau PET scan. They've grouped the people that have low tau on their PET scan, so not a lot of downstream damage. And they're able to show that they actually do a little bit better than the ones that have all the different tau PETs mixed in. So the earlier you can get to this, the better. There is some indication that maybe in the future, using a tau PET scan will help us stratify who will get the best benefit from these medications, because we'll talk soon about the side effects. These are not medications you want to give if you're not going to get a good result, because there are some drastic side effects that could happen. And then here again, the amyloid PET burden really gets much better. And one thing that they found is that up to maybe as high as 3/4 of the subject participants at a year and a half were able to get off of the donanemab because they cleared all the amyloid. So when we talk about pricing, remember that, because pricing may depend upon how long you stay on the medication, right? So side effects, what are the side effects? And certainly these are infusions. You go in either every 2 weeks or every 4 weeks, and you get an infusion. Just like if you had rheumatoid arthritis, you get an infusion, multiple sclerosis, same kind of idea. You have infusion reactions. Some people get headaches or they get rashes or whatever, and they often will pre-treat with Benadryl. And then there's these amyloid-related imaging abnormalities. Of course, there's an acronym, ARIA. And then there's ARIA for brain swelling and ARIA for brain bleeding, okay? And again, ApoE makes a big difference. So if you're going to get the medicine, you have to get ApoE tested, genetic testing. Most patients and subjects who have these problems are not symptomatic, but you have to have repeated MRI scans, and they will pick it up on MRI. So most people that have bleeding in the brain do not die from it in this because it's microbleeding, and the same thing with the swelling. But there, you can get a seizure. There have been people who've died. Why does this happen? Well, we've talked about the amyloid. The amyloid is also deposited in blood vessels. And so if you're pulling it out and you kind of nudge the stuff in the blood vessels may become more leaky and more able to cause swelling in the brain because things leak out, cause bleeding because they might rupture in a small way, that sort of thing. So, getting rid of amyloid is great, but you can also be causing some other issues. So if you look at people who have no amyloid, no ApoE4, if they have one ApoE4 and the other's like ApoE2 or ApoE3, or they have both ApoE4s, because remember, you get 2 chromosomes, one from your mom, one from your dad, so you're going to have one of each. If you have 2 of them, your percentage of the people that have this swelling in the brain is 30 to 40%. Okay, that's pretty high. Now, remember that I said this can be very asymptomatic, and they just find it on the scan, and maybe they stop for a while, maybe they restart, but it's pretty high. So some places do not take people who have 2 ApoE4s right now. They just won't, like the Mayo Clinic, won't, at UCSF, the San Francisco campus, they'll take some, but very highly selected. And they have to sign extensive waivers because this is an issue. And then that's the brain swelling, and here is the brain bleeding. And I couldn't find these data broken down for donanemab just this way. But again, with lecanemab, it's 40%. So it's high, okay? So it's something you have to think about, something if you end up using these medications with patients, the patients and the family need to be very well versed in what the downside is, and also what the upside is. What can you really expect? And then let's talk briefly about cost. The lecanemab is $26,500 a year, and the donanemab, what they put out there is somewhat similar. It varies whether you stay on the medicine or not, okay? Medicare patients are followed in a registry, and that allows Medicare to gather real-world data on what's happening, because these drugs haven't been out very long. They have lots of side effects and that sort of thing. Briefly, I'm going to, and they also are hoping it'll help with studying diversity outcomes. I'm going to swing through who can receive the drug, who cannot. You have to have either mild cognitive impairment or dementia. If you do not have symptoms, you cannot qualify, even if you have a brain scan that shows amyloid. You can't qualify for the medication. You must have amyloid, either by spinal tap or PET, and you must have a care partner who can help you with this medication. A couple other big things are you cannot be on anticoagulant drugs. So you can be on an antiplatelet drug like aspirin or Plavix or something, but you can't be on Coumadin or some of the apixaban, some of these newer medications. You cannot have had a seizure as an adult, or certainly not multiple seizures. You can't have too much hardening of the arteries in your brain, because that would put you at risk of bleeding. So take-home messages about the anti-amyloid therapy. It's difficult to generalize the results with the lack of diversity in the trial. Not all patients qualify. We went through that. That doesn't reverse or stop the pathology. ApoE status can increase the risk of bleeding and swelling, and the tau status may have implications in the future, but we're not using it clinically in the guidelines yet. There are some pipeline treatments. This is a slide from Dr. Cummings, and I wanted to just bring it in here to show you that there are lots of different types of medications. Let me see, medications that are being considered for Alzheimer's disease. There's multiple disease-modifying therapies in phase 1, phase 2, and phase 3. There's these new kind of small molecule therapies. There's some neuropsychological treatments for symptoms. And then there's kind of cognitive enhancement therapies. So there's a lot of different therapies that are out there, too much to talk about today. I would like to just stop with a couple of preventative measures looking at that. It's super important to realize that there are potentially modifiable lifestyle risk factors, okay? These are things that can be done to lower your risk of dementia. This doesn't mean you can necessarily avoid it, or that if somebody is at fault if they get it. It just means that, that there are things you can do. And there are 12, according to the Lancet report, there's 12 potentially modifiable lifestyle risk factors, and this is something that everybody really refers to. They had 9, they added new ones in the 2021: excessive alcohol consumption, head injury, and air pollution. And you can think about how air pollution might interact with what we've been talking about with ethnically diverse populations who maybe live in different parts of the city, or underserved populations who are more exposed to air pollution. So tackling all 12 is estimated by this report to perhaps prevent or delay up to 40% of dementias, and this is all-cause dementias. And in high-income countries, it turns out that now the incidence of dementia is lower for people who were born later. So it's really improving in high-income countries. I just wanted to show you briefly the 12 early life factors include education. Again, this is a marker for brain stimulation. So even people who are not highly educated, if they're using their brain and thinking through things, and we feel it's probably just as good, just hard to measure. And then we have hearing loss. So if you have or need hearing aids, definitely wear them. High blood pressure, traumatic brain injury, alcohol we talked about, obesity, smoking, later life, depression, social isolation, physical activity, diabetes, and air pollution. There are individual and social problems here, and they recommended some strategies. Treat your high blood pressure, use your hearing aids and get them if you don't have them yet. Don't drink as that much alcohol. Prevent head trauma. So, people that go do crazy things and don't wear a helmet, that's kind of, not good for your brain. Stopping smoking is super important, regardless of how old you are. Reducing obesity and reducing the link to diabetes is helpful. And then continue to be active, particularly midlife, and it's probably so in late life physical activity, as active as you can be. Obviously, check in with your physician. Don't go run a marathon tomorrow, but work with your limits and gradually build them up. And then the last slide really talks about the population-wide risk factors and what can be done as a society, prioritizing childhood education and social public health policies that reduce high blood pressure risk in everybody, and develop policies that encourage physical activity, social and cognitive activity across the life course. So, by building our cities to be very car dependent, we've taken away some of that. And are there ways that we can build that back into people's life? Reduce the risk of brain injury, including in occupational settings, and national, international policies to reduce air pollution, and continue smoking cessation efforts. So with that, I'm going to say that we will start the panel discussion, and so we'll go over and answer questions.
While we're getting our panel out here, today, if you would like to ask questions from the audience, you're going to need to come up to this microphone. Okay, we will not be wandering around. That's so the people on Zoom can see you. So if you'd like to step up, please do so. Ricky, do you have a question you could start with?
We have no questions online, so we'll start with you in the front.
Hello, that was very interesting. Thank you. We have a lot of tests that we do for baseline information on our health. Is there going to be something for this type of activity? Thank you. Oh, and also I was curious, just as an aside, autism. I was just wondering how much autistic people might be affected. Thank you.
Okay. Well, I'll take the first part, at least the beginning of it. In terms of, are there going to be tests for this? I suspect yes. Already, Medicare pays for a cognitive assessment of patients, and so doctors can perform that. At the moment, that's what we have. But as we get better and better drugs, remember I talked about the fact that we wanted to move earlier and earlier. You know, I could see a time when we're going to be starting to test for amyloid super early, because we will have therapies that we will be giving to people who are asymptomatic, don't have any symptoms yet. So I think that's coming, whether that will be a blood test or some of the other tests that Dr. Lent was talking about. I think it's very interesting.
Yeah, I mean, I think in an ideal world, if people could get this type of testing and also get neuropsychological testing, I'm a neuropsychologist, but what we do is we give people tests to evaluate things like their memory early. And if this was done at baseline, and then we could test people yearly and see changes in memory over time, then you could pick up all of the early indicators. So that would definitely be wonderful if that happened. And you know, with these tests evolving and getting much better, that would be great to catch people early, and that's always the ultimate goal.
And I'll just add that, you know, the earliest protein to form is beta amyloid, as Dr. Alvin was discussing, and it's been the primary target of all these new drugs. But the diagnosis of it in blood and CSF has been a challenge, and scientists are still trying to figure out. There's a lot of inconsistencies depending on, you know, what genes you have, you know, how, you know, most Alzheimer's disease is sporadic and of an unknown origin. And then there are those that have it because of specific genes. And those that have, you know, the familial form, which is the genetic form, those are easier to diagnose. Sporadic is much harder because we don't know where it's coming from. The levels of beta amyloid can fluctuate, and it's a really, you know, wicked challenge that we are facing.
Yeah. Unfortunately, she stole my first question, because if you can find out the development of the amyloid at an earlier stage, you can institute some therapies, right, that would prevent the progression of the level. Second question is, or actually a couple of things. One is, do you have any pharmacists involved in your research in managing the medications within the studies? Because I practiced for 40 years, and we don't seem to be able to get a place at the table a lot of times in developing things or managing medication therapies. It all falls on other members of the health professions. And the third thing is there any reason why they didn't use more diverse patients within their studies in underserved areas to get a better baseline for, you know, for using the therapies and things like that? Why there was a higher number of white patients in the studies versus the people that we know don't have access, and it would be more beneficial to find out about that.
We do have a chemistry professor, Dr. Shantanu Maitra, who has worked on drug development, who is a colleague. And in terms of getting a more diverse population in studies. That's extremely important, particularly for clinical trials. There's different barriers to being in studies for different diverse groups that have been studied, and we're always trying to reduce those barriers. So for instance, if we talked about poverty being an issue. Now, a lot of studies are enrolling people from 8 to 5, Monday through Fridays. And so if somebody is still working or a family member who takes them to appointments is working, they wouldn't be able to come be involved in the study. They might be in rural populations where it's difficult to get transportation to get to the medical center. And there's also an issue of, trying to build trust with the community in people being involved in these studies. So there's a lot of work that's being done that's been done in understanding this issue, because it's very important that the treatments that are developed that work well for everybody. So definitely increased diversity in clinical trial enrollment is a paramount issue.
And I think it's one that's really being pushed. I mean, for example, we were part of a trial that looked at amyloid PET scan for Medicare. And they went through one trial and we don't have nearly enough diversity. So they designed the second trial to get more information. And in that trial, they specifically said, we need enough people from diverse backgrounds, and that took so much longer to fill up than the other ones. It was just very difficult, which just illustrates the difficulty. It doesn't mean it shouldn't be done, and I think the NIH is really dedicated to that. They have rolled out, guidelines and all that sort of stuff, but. And like the FDA, also has been doing that sort of thing. But it's hard to do. It's hard to do.
Yeah, there's many, many initiatives now to increase diversity because we want the best treatments for everyone.
And historically, up until about 15 or 20 years ago, they just assumed if a medication worked on a white male, it would work on everyone. So that was historically who were the subjects.
Yeah.
Okay, we'll take a question online. Would you please repeat the 12 individual risk factors?
Well, I will try, but it's on the slide. High blood pressure, treat your high blood pressure, keep your brain active, so education is our marker for that. Avoid obesity, avoid diabetes, avoid depression, avoid social isolation, avoid head trauma, make sure your hearing is good, so get hearing aids if you need those. I'm skipping some obvious ones. Yes, smoking, I didn't say that already. Okay, no smoking. Alcohol, that's the right, and then air pollution. So, and there's probably, most of them are pretty clear. I do want to say, we talked a lot about these medications and trials and stuff, but it is super important that you really think about these lifestyle changes and you think about them early. It's not as clear how good they are, though they still continue to help once the process really has taken hold. But if you are a young adult, a middle-aged adult, an early post-middle-aged adult, really focusing on exercise, sleep, socialization, healthy diet, mental exercise, all of those things, super, super important. And then avoiding, all the bad things like smoking and drinking too much. So I apologize if I missed one of that, but in the Lancet 2020 report, they do go through all of those risk factors and give the recommendations.
And I'm impressed you just watched Dr. Alving, a memory expert, take a memory test right now. I want to add on to about remaining cognitively active, being a way to reduce risk factor. That's why it's so great that you guys are all here, still learning, hearing about neuroscience, hearing about neurological disease. This is really great what you're doing. So.
Okay, we'll go back to in person.
Hi, thank you for sharing all that information. I have two questions. One of them, you kind of touched on it. In addition to preventing, doing things preventable, how about the impact of good nutrition? Like you hear a lot about fish oil, you hear a lot about certain things, and how is that? I know it doesn't hurt, but how helpful is that? That's one question. And also, we mentioned that we, in general, have neuron deterioration, that we lose things. How would one to know, oh, this is part of me getting older versus, oops, I got to do something. This is not right. Because I don't want to live in fear, but at the same time, I want to be preventive. What would be a suggestion?
So I can start a little bit about nutrition as it relates to one of the biological factors. And so Dr. Alving had mentioned that APOE is a really critical element and not fully understood of how it plays a role, but what it is responsible for in both cardiovascular system and the brain is actually for lipid transports. And so its ability to regulate levels of fats and cholesterols in your body is what its main job is. And so how it's actually connected to ultimately developing Alzheimer's disease is still, being studied. But some thoughts is that, high-fat diets and things like that, if you have these other, risk factors based on the variant of APOE that you have, can ultimately contribute to developing Alzheimer's disease. And so the literature I have seen, it's high-fat diets increase susceptibility, and that connects to things like obesity too.
About how to tell the difference between healthy age-related changes in cognition and whether it's the early stages of the disease. So the only way really to know is to go in and get evaluated, and then by a neurologist. And you could talk to your primary care and get referred to a neurologist, but that's what I would recommend. And then it would involve an evaluation that typically involves an assessment from the neurologist, neuropsychological evaluation to look at your functioning and evaluate your memory and other cognitive functioning, and neuroimaging to put all of the different pieces of the puzzle together to say how someone's doing at that point in time, if they have mild cognitive impairment, if it's just healthy aging, if it's Alzheimer's disease or some other condition. So that definitely is the way to go if someone has concerns about their functioning.
Okay, we'll take one more online and one in person. The question online is, in the movie The Notebook, the Alzheimer's victim suddenly remembers who her husband is for a brief while. Is that a realistic situation?
I'll take that one. It is certainly true that people have different periods of lucidity, and I don't think there's anything that would say to me that couldn't happen. I haven't watched that. I've heard about it. I haven't watched it. But there certainly are times when patients can recognize things and then not recognize things, family members, that sort of thing. So it's not, it's not out of the realm of possibility.
Okay, thank you.
Okay, I'll follow up on that. I've been a caregiver for my wife for about 8 years, and the last 3 years she's been in a memory care center. She doesn't know my name, but she knows me every once in a while. And I think it circles around. It takes her a couple minutes to know who I am. I also know that Senate Bill 639, I believe it is, requiring doctors and primary care nurses and that be educated, because there's 40% will not make the diagnosis, 40 to 50%. They're uncomfortable in that. And I was wondering what you feel you can do about that in your field. And I also have one other question up there.
Well, I will answer that one first, and if you guys want. But that is exactly a problem that we see out there. And we've been participating in a number of studies. There was the Dementia Care Aware initiative, which was a 2.5-year initiative run through the UCSF San Francisco campus that it was for California, and its goal is to train as many primary providers, including nurse practitioners, MDs, PAs, in how do you initially assess patients, particularly older patients who are at risk, and what do you do if you find a problem? And so that was a huge initiative. We're also part of an initiative called Project ECHO, which is sponsored out of the San Francisco campus, where we meet online for a series of 8 to 12 sessions every other week at lunchtime on Thursdays, as it turns out. And we have a short lecture session by the experts, and then a presentation of a case by a primary care physician or provider who is participating, and then a discussion among the people, including the experts, to kind of give information about how to deal with this. And these providers learn a lot at these sessions and really go back energized, and we've now started an alumni series. So if the providers have gone through, we have different information that we can give in these didactic sessions, and they can present more complicated patients. And let me tell you, they're presenting very complex things. And then the last thing that we're doing is we've been participating for the last 5 years in a study where we train, where we're validating a toolkit, which is something where the providers can take a history, and I think the history is one of the most important things, and we're training residents in primary care, and now there is an NIH grant to extend this study into the primary care community and see if we can refine the toolkit so that people can use it even without extensive training. So there's a lot of work being done, and I think you hit on a really good point.
Okay. Yeah, the other thing is there's a number of care facilities, and I was just wondering if Fresno State was planning to have a training facility where you could really do some research, because most of these facilities are filled with, and I don't use this word for them, but they use it, unskilled workers, and it's low pay in that. Whereas you can do an interdisciplinary work with psychologists, speech therapists, PT, and all that, where that could really be a benefit, because now it's like a holding area, and then finally, something to be done for the caregivers, because where my wife is at, and it's a pretty good place, but it has faults. There are 60 residents, and there's only 10 of us that visit every day. And it's really sad. It's like a holding area. And most people are in denial in that, and it has to be something done for the caregivers to make them understand and be a part of the situation. And that. So anyway, thank you.
Thank you.
Yeah, and I was going to just add that really is the purpose of our Brain Health and Sciences program, is to really try to address the broad range of discrepancies. And so we're bringing together a lot of researchers, but the main goal is to ensure what we are doing positively impacts the community in a real way. And absolutely, that's being able to offer a resource to caretakers would be a fantastic avenue to explore, and I'm definitely taking that to our group. Thank you.
One more real
Thank you,
quick.
Pam. I was going to ask you about, there was a study sometime back about anti-glycation products, and the subject of the item they were just talking about was carnosine. Do you know anything about that? Did it just die out? They said anti-glycation products, and carnosine was in that study. But that was been a few years back. Do you recall anything about that? What happened to that?
Yeah, I think this is always the challenge. I'm sorry, I'm unfamiliar with that specific trial, or study, but this is such a common thing about research and then how it's portrayed in the media. And it always gets thrown out that there's going to be this groundbreaking new thing that's going to cure all, and then it disappears. And so I think even when Dr. Alving was talking, she's like, yeah, there was this drug that was all the rage. Then she said, I'm not going to talk about it anymore because it's not. And I think that it's a combination of the way that science works is researchers have to be promoters because we need to get funding. And then the media picks those things up and they promote it even more. And 99% of the time it goes nowhere, unfortunately.
Okay, thank you very much, everyone. If you have additional questions, you may email them to the Osher email address. There's cards out front if you want to pick one up, and we'll forward that to our panel. But we have gone way over our time for today. So please thank everyone. Okay, thank our panel. You've all been wonderful. Great questions, too.